We can't continue without talking about CAR T-cell therapy, recently approved, outstanding response rates, but significant toxicity issues. Bijal, can you give us your perspective on where this fits in?
Absolutely. I think that CAR T, without question, is extremely potent. I think what we lack in the adult space is information to guide us on the durability of that response. We need that. We need that before we can really understand how do we integrate this, not just for relapse refractory disease, but as a consolidation perhaps following an induction for those MRD positive patients, but perhaps even the MRD negative patients, right? I mean, if we have and I understand the toxicities, and I'll come to that in a minute, but in treating a patient who's MRD with a very low disease burden with CAR T is actually exceptionally well tolerated. I think Jay Park had presented this data from the Sloan Kettering experience. And not only that, the patients who got CAR T without a transplant, again, small numbers, but visually did much better than those who got a transplant for MRD positive disease. Suggesting, again, not so much that we need to exclude transplant for patients post CAR T, but rather we have an effective tool for treating those patients in the MRD positive. And again, I'm going to say it here that my goal is to move it up front for all my patients, having treated several patients on the Kite CAR T trial. It can be extremely effective. Coming to the toxicity, and I can elaborate on the efficacy if you'd like, but coming back to the toxicity, when I went back and looked across all the trials that have been done, recognizing that we're still waiting on data from Juno to emerge and be published, the overall risk of death is in line with an autologous transplant. It's about 3 to 5%. You look at the duration of hospitalization, also in line with an autologous transplant, anywhere from 2 to 4 weeks in the hospital, and most patients are out. This is becoming a very effective tool, and I think we're going to see it used more and more. You can tell I'm more than biased, I'm excited, because we've really been compelled by some of our experiences administering this to our patients.
It's definitely exciting, but I think this particular generation of CAR T cells does carry a lot of toxicity, and it requires extreme expertise to administer this therapy to patients. And so I don't think that 10 years from now that this is the format that CAR T cells will have. I think there's going to be innovation in our ability to control the activity of those cells, so that if we start to recognize higher grade CRS or higher grade neurotoxicity, we'll be able to augment the activity of those cells so that we can kind of shut them off, put them in a quiescent state, deal with the toxicity in real time, and hopefully then turn them back on. And there are various technologies that are being developed to do that. So I think we're learning a lot, and it's always the case that you see more toxicity post-marketing than you saw in clinical trials because there were strict eligibility criteria. And I think we need to wait and see what the real-world experience with CAR T cells is going to be before we start thinking about moving it to earlier lines of therapy. And I do think we have to think about the economics of it. If a therapy costs $500,000 just for the drug, and then the hospitalization may even possibly double that, is that something that we can afford to do for every ALL patient when we've actually been curing ALL patients, a substantial portion of them, with much cheaper therapy? And so I think what we need to do is we need to figure out who's going to fail that cheaper therapy, and it'd be great if we can move some of the other agents up front so that patients aren't on therapy for 2.5 to 3 years so that they can get back to their normal life earlier. But right now, I'm very skeptical that a CAR T cell up front is going to be the way to go.
And this is where I'll challenge you.
Hopefully over time the cost will come down as well.
Well, but this is where I'll challenge you, because you mentioned 5 courses of Blina. It's $90,000 a month. That's just the cost. That's not even the charge, and that doesn't include complications for hospitalization. If we're talking about inotuzumab, again, for 3 weeks of therapy, we're talking about something around $100,000 as well. And so we have to keep in mind, as we talk about the upfront cost, that we have to sort of compare and contrast with what else is out there. Believe me, I'm the last person that wants my patient to pay $475,000. That's not at all, I think, what any of us on this table want. But I just want to make sure we keep perspective with the other therapies that we're actively administering right now as it relates to cost. As it relates to toxicity, I completely agree. What we're going to see off trial is likely to be more toxicity. I think that, and I imagine that as autologous transplants were coming into phase, at one point we were doing it for breast cancer, we were also seeing more toxicity than we currently see. It took us years to achieve that sort of basement of 3 to 5%. When I express my excitement, it's excitement that relates again to the Tisane-Jalucel experience.
Tisagen,
I'm not even going to try and say it again. You know, it was the durability that was observed in that trial in a pediatric population. And I'm hopeful, just, you know, again, because it's a similar mechanism for adults, that we can approximate that.
And I think I'll maybe be the CAR T-cell skeptic voice, maybe in the world, but perhaps at least at this table. I mean, I think we have to pump the brakes a little bit. I mean, I think it's an exciting therapy, and there's a lot to be optimistic about it. But, you know, we really don't have much in terms of even remotely long-term follow-up, but particularly in the adult experience. It's really unclear how good these CRs really are. And I think the other thing that is important to point out, you know, at least in what is currently the labeled experience or labeled indication for it in the relapsed refractory setting, if you look at the Eliana study that led to the approval of Novartis's product, about half of these are among the most highly selected patients maybe ever enrolled in clinical trials. I mean, these are incredibly selected patients because there was such demand. Despite that selection, I mean, they're really sick, but very selected. About half of them end up going into the ICU because of cytokine release syndrome. I think about a quarter of them ended up on dialysis at some point, and these are kids, right? So, I mean, it looks like maybe, you know, again, newer generations of CARs, better patient selection, better understanding of the biology, better intervention strategies, tocilizumab and so forth. We're going to get there, but I think we've got a long way to go before we're going to be talking about replacing traditional consolidation chemotherapy with CAR T-cells.
And we're still not going to know whether they need the allo after the CAR T-cells.
Right.
You know,
But to be very clear, we already now have a frontline study with Blinn and a frontline study with Inno. And I don't think, we just completed the randomized study with Inno, it was published in the New England Journal a year ago? I mean, I think we have to be prepared for the fact that, you know, as we generate these effective therapies, the goal is to integrate them.
Yeah, and I don't disagree with that. And I think, you know, I think it's the Children's Oncology Group is doing a frontline CAR T-cell study, and they're really in their like ultra high risk patients. So the problem is,
which are the young adults,
right, and that's
by
true.
definition.
Yeah, but I mean, it's going to take years for that study to read out, and that may give us the first point. And again, therapies are always, with all due respect to my pediatric colleagues, treating pediatric ALL is always going to be easier than treating adult ALL.
No, it's true.
So.
And hopefully the data that we share tomorrow night will further, will convince you. How about that?
Well, I think we need to keep in mind also that this therapy is, in a sense, even more restricted right now, at least, than bone marrow transplant. It's only can be done in specialized centers, and the physicians have to be certified to deal with some of these severe reactions. I mean, not only the cytokine release syndrome, but neurotoxicity, those kinds of issues. So we need to keep
there's
that
also
in mind.
limitations on how many products can be made over a given time.
Yeah,
I don't know if there's any limitations on how many products can be manufactured over a certain time period.